Good afternoon, everyone. Um, Today we have the Director of All India Institute of Medical Sciences, Dr. Randeep Guleria, as a guest at AIIMS Exchange. Dr. Guleria was appointed as the Director of AIIMS in March this year. Dr. Guleria joined AIIMS 23 years back and has been credited for starting the India's first department of pulmonology in the country. He is also the first Indian to have received a doctorate in pulmonology and critical care medicine. He's been on the expert panel with the WHO on immunization, on influenza. Under Guleria, AIIMS has done extensive research on environment and its adverse effect on health. Currently, under his supervision, they're studying the link between respiratory and cardiovascular functions and the quality of air. For a lot of us, he's also synonymous with that. He's the physician of former Prime Minister Atal Bihari Vajpayee. So welcome to the AIIMS Exchange.
Thank you very much.
First of all, thank you for having me here, and let me start by apologizing for being a little late, but I just got held up in hospital and then the traffic. So I'm not sure what are the issues that you would like to talk upon, but two or three things that I would like to sort of highlight. One is related to the health and things that are the changing pattern of health, the issues of our social structure and health as I see it, changing in the overall structure in health as far as the doctor-patient relationship is concerned in a broad sense, and then also talk about what AIIMS would like to be in the future and how I would sort of try and see that.
I live in the same colony for the last 15 years, and if I have fever, I don't know who's a GP I should go to. I can find out who's a specialist in what area, but that's a common problem many of us face. Where is the GP?
So I totally agree with you, and that is why I'm saying that we need to look at this, that the concept of having a family physician or a GP is going away. And in our country, it is very important. And in the West also, a lot of countries are actually going back to a family-based sort of family physician or a GP-based practice to begin with, and then going on to a specialist. We are actually going on in the other way around. So it's an issue of which way do we want to go. This is a model which is becoming more and more prevalent in the US. The GP model is more like the UK or the European model, where you still have a structured plan that you go to the GP will refer you to the specialist, and you cannot approach the specialist directly. Here everyone wants to be a specialist at the expense of no one wanting to be a GP, whereas not only in the city, but as we go to tier 2 towns or we go to the rural India, there is a huge need to have GPs, and that's why this whole issue of looking at Ayurvedic doctors or other people who can practice medicine is coming up, because we're not promoting a GP-based practice, and GPs are not coming up. And we're also moving into the era, like I said, of people wanting to do more and more specialized tests rather than using their clinical skills, and that is what we need to change.
Sir, as you mentioned the importance of clinical diagnosis, you're the director of the best medical college in the country. The fact that clinicians are going out of fashion, and clinicians like yourself, I may add, are going out of fashion, is there a problem in the way we are teaching our doctors?
So there is a need to have an sort of overview of the curriculum. There is a lot of need in changing the curriculum. It's not only how we're teaching our doctors, how we can modify the curriculum to make it more, let's say, student friendly, use innovative ideas which are now, you see, technology has changed so much. We have to move into even virtual teaching, more interaction with the students, have more of group discussions, case-based discussions, get them interested, rather than the didactic lectures which were there in the past. And also there is emergence of a lot of newer things in medicine which have to come into the curriculum. So curriculum has to change dramatically, both in terms of teaching clinical medicine, but overall in medicine. For technology, that has to be incorporated into the curriculum. So the curriculum has to evolve with changing technology, changing emerging diseases. I mean, no one, otherwise, the students will never know what is Zika virus disease, and there's the huge interest on Zika, Ebola for that matter. So there are a lot of emerging diseases which have to somehow find space in the curriculum, and we need to move out from things which are not important now.
So you're also a member of the advisory committee that the Supreme Court has appointed to the oversight committee that look into the
Unfortunate for that, but
restructuring of Medical Council of India. You also have Professor Paul along with you. You have an opportunity right now to sort of bring in these reforms in MCI. So have you spoken to MCI and
So
what has been the progress so far?
Most of the oversight committee is that this medical college didn't get approval or this didn't meet this thing, and MCI has not given necessary approval, or there was a lot of issues. But there is also a bigger mandate of looking at medical education in general and how we can improve. Let's say 10 years ago, there were more government medical colleges than there were private medical colleges. Today there are more private medical colleges and less government medical colleges. Almost 60% of seats or more than that currently in MBBS and in postgraduate courses are in private colleges, and lesser number are in government colleges. What does that mean? That means that two things. One is, some places competition is not being followed, it's more based on capitation fees and other things. So it's the quality is suffering. Secondly, some colleges are run or get approval without enough patients there, without enough infrastructure there, without enough faculty. I'm not arguing that we don't need more doctors in the country. There's a huge shortage. My argument is that should not be the reason why we should compromise on quality. So we have to develop a system of ensuring quality. Develop a system so you could have a common exit exam. All students, irrespective of which college they pass out from, have to give one exam which shows that they have this basic qualification to practice medicine in the country. That could be one option, but these are various options. So we are looking at that. That is part of. So when we had this initial meeting, we said that okay, this is one part of the policing part that we need to do, but that is probably not the important part. That is the day-to-day mundane issue of this private college is saying that the inspector was biased and didn't approve. But the other important issue is how can we improve the quality of education in the country, and it's both curriculum, but also with so many private colleges coming up, so many seats being increased. So government has increased the number of seats, at times doubled them in colleges, but the infrastructure hasn't followed. So we have issues even in our institute where now we have more students, but the lecture theatre is becoming small because it was never envisaged that we will have so many students. So we need to look at all of that.
Sir, also the archaic medical curriculum that you have. For example, psychiatry is now still taught in medicine in MBBS curriculum, whereas that's the biggest problem right now in mental health. But you have US and UK who have it as a separate subject. So when these guys pass out of MBBS, these are general physicians who can't really screen. So at one point of time you have a debate that you need more psychiatrists, but also you need to have more general physicians who can screen these things like simple common mental health disorders like stress and anxiety. Do you think we need to look at the curriculum per se, because we're still studying the curriculum which was what was there in 1940s?
I agree with that, but the issue is when we start looking at the curriculum, we also need to see the time that we have. If we say this is a 5.5-year curriculum, how are we going to get everything into that curriculum? So are we going to really increase the duration of MBBS, or are we going to structure? So already changes occurred. So either you develop a program where you say that we cut this and you add this and then you justify why you're cutting this and why we are adding that. Or we look at a system where we say that after your basic MBBS, you then see where you want to go and you develop a short module or a training structure where if you want to be more into general as a GP, you get training on mental health, you get some training on doing basic management of patients, whether it be conducting deliveries or, so it's more like a family physician training. Because medicine has changed from what it was 30 years ago in terms of, let's say, the knowledge that you needed then and the knowledge that you need now. And it's rapidly changing. And I'm so let's say lucky that I'm in AIIMS, so I have a lot of access to journals and other things. But think of a physician in a smaller town. He passed out, let's say, 10 years ago, and now he's set up his own practice. He's practicing. He is only dependent on what the medical representative comes and tells him as far as his knowledge gain is concerned. MR will come and tell him this is a new drug, this is very useful, and he will prescribe that drug without realizing that is it really required, because the medical representative has an ulterior motive to promote that drug. So we need to be able to develop a system of training and retraining our doctors so that they stay in touch and are therefore able to provide better quality medicine.
Doctor, if I can ask you about this whole business, of commercialization of healthcare. So one of the things is, of course, it's been very good in the sense that it has allowed us access, and many people access, because the government hospitals or system can't cater to it all. So that's the good side of this kind of flourishing private.
I'm not sure it's the good side, but
okay. But I'm saying that's the good side. 1 second. That's my question to you is that what you were referring to earlier, when you go to a private clinic or a hospital, the first thing they will say to you is have a battery of tests, and all kinds of tests, or even. And I know this from personal experience, that they suggested a knee operation and I'm still scarred for life with a test that was completely unnecessary, right? And as soon as the test was over and I paid for it and everything was over, he said, oh, well, you're okay, it's nothing. So what is is this the way it's going to go? And is there any way how do we look at this whole problem?
one of the issues that I really wanted to talk about is the change that has occurred in the patient-doctor relationship. And that is also driven by what you mentioned. And that has because I think the fundamental issue here is medicine a service or is it a business? You need to take a call on that. Many of us became doctors because it was something we wanted to do as a service. It was not as something that we wanted to do to make money. But values have changed so much. And therefore, medicine has also paid the price. I think 2 areas which have paid the maximum price is medicine and education. Medicine was something which was pure in the sense that a patient puts his life into your hands. And you have that huge responsibility of being fair to that patient and doing the best you can, keeping in mind not only the needs of the patient, but the social structure the patient comes from. We are moving more and more towards a business model, where everything is looking at, if you are going into medicine, whether it be medical education, whether it be patient care, it's depending on the money that you can make. And that is where we need to have a real, I would say, thought process. And I don't think we're moving in the right direction, but I'm not sure how to change it also.
Sir, if I can add a question to that. Now, has it come from state abdicating its responsibility in healthcare? Yes.
I feel that the state has to take the responsibility of education and healthcare, because those are the fundamental parts for any health system, and the very fabric of a nation is dependent on good education and health for the citizens. There is no dearth of good hospitals with number of patients. We just need to add a medical college to them and build in the structure for that. We don't need to go down having huge fanciful private medical colleges which are state of the art but no patients there because they can't afford to go there. So we need to really rethink the whole process of medical education and patient care, because the divide between corporate hospital and the public sector is becoming huge. The load that we see in a lot of public hospitals, and it's not only AIIMS, you go to any government college in a small town also, there are patients on the floor, there are patients, why are they there? Because they can't afford to go out. It's not that they're there by choice, it's there because of desperation. Where do they go? They can't afford to go to a corporate hospital, they can't afford to go to a private hospital because it's prohibitive for them. And we have sort of abandoned them in a way. So we need to really think of that.
Sir, coming back to the new AIIMS, these institutes are having problems getting faculty. So, which do you think government should go for something like this of quoting your salary or somehow match salaries, or are you in favor of a transfer policy from Delhi AIIMS? Right now, you send only people who are willing. So instead of that, a regular transfer, government transfer policy where you can be transferred anywhere in any of these AIIMS.
I think first of all, the question is why are people not joining AIIMS, the new AIIMS? Multiple factors. So some junior faculty want to join AIIMS, but they want that they should have a nice running hospital, which is not happening. I sometimes tell them you have to understand that when AIIMS was formed, AIIMS Delhi was formed, the initial faculty actually was involved in the structural design rather than the patient care. And I know that the initial professors actually sat on bricks and looked at, this is going to be my ward, this is going to be the OPD, and then it dwelt. So it's a process of evolution, and the doctors there have to be a little more patient. We want everything very quickly now. The younger generation wants that, that is one. Second is the pay package. The third is trying to look at their needs and supporting that. So if you get someone who's very enthusiastic, and you don't give him what he needs, so people come to a hospital saying that I would want to have, say, a cath lab, or I want to have a dialysis facility. If that is not there, there is a sense of frustration. So I think we need to really look at how we can provide the needs for the people who are coming there, talk to them, and then work on a dedicated group. Because you see, paying them enough money is not the only solution. And I would argue that we would need people who are dedicated and who come there irrespective of the salary and are willing to work for building the institute rather than just for the money that they get. If you just come there for the salary, you may still do nothing, and you may just say, okay, I'm getting a good amount of money. And we need people who the newer AIIMS needs people who are willing to toil in and build that into an institute which has a reputation. Otherwise, it will become like any other general hospital.
So only let's look at the entry. NEET has come under the scanner now. The argument is that people who go to coaching centers and have access to CBSE schools are able to crack this exam. Do we really need to rethink on our entrance examination to medicine?
Totally. As a matter of fact, not only for medicine, we need to look at the examination structure at different levels. And I'll tell you why. We have students who come in after MBBS who have not had their basic internship training of even how to put in a line, how to put in a urinary catheter, because for the last 1 or 2 years, they've been sitting in the coaching center and mugging the MCQs rather than working in a hospital and managing patients. So we have to move either to a system of examination which looks at clinical skills rather than your theoretical mugging knowledge.
Is one common medical test the way to go, the way NEET is panning out right now?
Entrance,
yeah. So the issue here is that if you're looking at a competitive system where you're going to have the private colleges and the government colleges working at one, in the long run we will have to have one exam, because otherwise it will become very, very complicated. So I personally feel that one examination should be there, but we should look at the differences which are occurring at state level, and this is what happened, that there was a total different assessment mechanism at a state level as compared to the national level. So that has to be harmonized so that it is more homogeneous both at a state and a national level.
I have a related question actually to hers, and it's that we tend to say here that the Indian doctors are very good, but that the nursing care is very poor, and especially in what you've talked about, communication. Often it's just a language problem, but in general this is. Would you like to comment on
And
this?
AIIMS nurses, if I may add, are, I think, among the worst when it comes to behavior.
So nursing care, I would also say there is a difference from where you come from. I've seen nurses from all over India, and I would say the nurses who come from the south are much more involved and dedicated because they have that training. Many of them come from institutes which have the background of service, especially from Kerala, and they have a higher level of education, and therefore I find that they are more dedicated. Sorry to say, but I find nurses who come from the northern part are not that good. They are more into, and they are becoming more sort of demanding. It's it's an issue of being able to serve rather than looking at it as a job. And nurses also.
Colleges just better in the south, you're saying, for nursing? Are the colleges just superior in the south?
I think there they focus a lot on the compassion which a nurse should have. The issue of how it should be with, let's say, Florence Nightingale and that type of thing. In the north, the nursing colleges are more churning out numbers rather than looking at it. So again, that it boils down to the same factor that when you teach, you have to teach that compassion also, which has to come in nursing.
You mentioned how in the West, better water, better sanitation can prevent a variety of diseases. So, what sort of a toll is the air in Delhi taking on its citizens, according to you?
Okay, so that is something that we've been looking at as a cause of concern because pollution levels in Delhi have continued to be high for a long period in time. And I've always argued that this is something which is a silent killer because the number of people who die because of the effect of air pollution is based on studies and the effect that you see. It's not a direct link that you can always show. And that is why a lot of policymakers challenge it. But there is enough data from the London smog, from Los Angeles, from various other parts of the world in the 50s and 60s when they had a similar problem to show that this is causing significant morbidity and mortality. So we don't need to reinvent the wheel. That is definitely there. But what is happening is, can I point and say that this person died because of air pollution and this person did not? I cannot do that. I can say, yes, this person died of dengue or he died of H1N1. So it's a silent killer in that manner. But the number is still huge. And it's an acute effect, which is the mortality, but it's a chronic effect also. So if you look at what is being said by various cardiac associations, the European Heart Association also, it says that living in an area of high air pollution is as high a risk factor for heart attacks as is high cholesterol, high blood pressure, or smoking. And we've shown that. We've done studies where we've shown that if you look at blood samples of people who are having high exposure to air pollution, their inflammatory markers are much higher, suggesting that they have accelerated atherosclerosis. So, higher chance of heart attacks in later life, retarded lung function in children who are growing in and living in this area. So, I feel that it's a silent killer for which we need to do something. It is also going to have a long-term effect, and therefore a multi-pronged approach is required. So it is something that we need to do, but why should we wait for another 15-20 years and gradually do that? Why can't we understand the problem and find the solution and do that right now? That's what I feel. Why do we need to have more people who have to die before it becomes an issue rather than doing it right now? So there is a need to do something urgently, definitely. When we talk of pollution, we also miss out on what we call indoor air pollution. You see, there is a huge burden of indoor air pollution also, because still 60% of India uses biomass as a means of cooking, whether it be wood, cow dung, and this is done in kitchens which are not properly ventilated, and there is a huge burden of indoor air pollution also, and we need to look at solutions for that also.
The euthanasia bill has just come back into the news, this living will clause. I want to know how you weigh how much we need end of life care, how much legislation does it need right now? time goes on, more elderly population.
So I think it is a very important issue that needs to be discussed, and we need to have some policy also on it. There are issues of decreasing suffering and looking at the quality of life rather than the quantity of life, especially in patients who have terminal illness. Very, very important for terminal cancers, also for people who are critically ill in the ICU and on ventilators for days with so many tubes inside them which actually are of no use. But I think there needs to be a bigger debate as to how we can look at decreasing the suffering of individuals who we know are terminal, and that is where euthanasia comes in. The challenge is always people say that it can get exploited. That if you have a system, and especially where there's a large amount of, say, property involved or things like that, that people may do that. And but if an individual has already given a living will that this is what he wants, there should be some sort of a legal support to that to strengthen the hands of doctors to do it.
AIIMS has, the center, cancer center at AIIMS is a pain-free center. You have a dedicated palliative department which looks into, these things. But the big, not just government hospitals, even the big corporate hospitals, they lack palliative departments. How do you sort of address this issue?
So first of all, we've decided, and we're trying to do this, to make AIIMS what I call a pain-free hospital, that we should manage not only in oncology but in all other departments, and we're looking at a whole protocol of how we can decrease the suffering of people across the board. So you have patients who have end-stage lung disease or end-stage heart disease. They are sort of pre-terminal and they are suffering. So how can we decrease that suffering? If we have nothing to offer them in terms of treatment, at least we should offer them something so that they are not suffering. And that is something that we need to do. Also, we need to develop programs, and this is what we're doing, that for palliative care we have an MD program also, but we're also looking at having regular workshops and courses which is being done by the oncology department for various institutes, and build a network of how to develop palliative care which goes down to smaller cities also. At least we should offer better quality of life even if it is for a shorter duration. We can't just say that this person has got just a few weeks to live, so let him just live like that. That is not an acceptable statement.
The Prime Minister earlier this year said that he would get a legal framework where the doctors have to prescribe generic drugs. At AIIMS, I've seen letters where the RDA has written that only 1/6 of generic drugs are available right now. Also, the consultants, there are very complex antibiotics which are prescribed to patients, which are really not available as generic drugs. So do you think India is prepared for that sort of a transformation, that we are moving away from commercial drugs to just generic drugs?
So first of all, I think it's very important to understand what we mean by generic drugs. And I have a different sort of classification, so let me try and explain my classification, and then we'll see how you get the idea. So one is the original drug, which is the branded drug, which is patented and made by the original manufacturers. Then is what we have in India, the branded generics, which a company which is Indian based uses the laxity in our patent laws and makes the same brand, but the brand has a name which sells with that brand because it is attached to that, and that was there with a number of companies. It could have been what was initially Ranbaxy, Cipla, Sun, all of them have what I call branded generics. They have a brand for that, and that is used for that. And the other is a generic where there is no brand. It is just the molecule's name. So you could have paracetamol, which is Crocin, or Calpol, which is the branded, let's say, generic, or Pacimol, which is another company which makes paracetamol, and the generic, which is paracetamol. So the branded generics in a way are also generics, but they are promoted by an Indian company which is making it, whereas the original is being made by the company which manufactured it, which could be a multinational company. So those are three broad frameworks that I have, and I sometimes feel that we need to be clear on that, because there are molecules which are, and there's an antibiotic which was made by the original company. It used to be, the one capsule or one tablet used to be for 110 rupees. The branded generic which was made by Indian companies was something like 15-20 rupees. So the huge difference. And the generic would be something like 5 to 10 rupees. So those are the price ranges that one would see. The issue here is not about generics per se, it's about quality control. The license to make a product is given by either the DCGI or the state DCGI. And the DCGI argues that they don't have enough inspectors to inspect all the sites. There is no quality control in terms of people seeing that the drug that is made, the dose is enough, the pharmacokinetics is good enough. And therefore, a lot of physicians are worried about the generics because they get made in facilities which may not meet up to the standards. So unless we are able to solve that problem, that all generics will have good quality control, there will always be reluctance among physicians to use the generics, not the branded generics, but the generic generics. So that is where the whole challenge of the generic drugs lies. So I would feel that we should promote generic drugs because they are cost effective, but at the same time, we cannot play with health. If we are able to have good quality control as far as generic drugs are concerned, yes, they should be used, but a system should be in place so that there is confidence that these drugs are effective.